Tissue integrity. The main function of the skin is to provide a barrier against injury, infection, ultraviolet radiation, and fluctuations in temperature changes. It has a vital role in the perception of touch, pain, pressure, and vibration. Other functions of the skin include elimination of waste and to help support underlying structures, as well as a synthesis for vitamin D. When we look at the risk factors for impaired tissue integrity, there are expected changes across the lifespan that causes skin to be vulnerable at certain times, thus placing clients at a greater risk for developing alterations in skin and tissue integrity. In particular, clients that are at the most risk are early and late in their life cycle. During infancy and early childhood, the skin is immature. Maceration or an irritation of the epidermis that is caused by moisture, and dermatitis, which is a red skin irritation that develops when the skin is exposed to irritants such as feces, urine, and wound secretions. For an older adult, the collagen stores decrease, the skin thins and loses elasticity. There is a greater risk of skin tears and tissue trauma. Skin exposed to sun may exhibit premature wrinkling, thus accelerating the aging process. The most frequent skin problems associated with skin frailty are skin tears, pressure injuries, which is a localized damage to the skin and or the underlying tissues as a result of pressure or pressure in combination with shearing forces, and infections of the skin, such as cellulitis, which is an infection of the superficial layers of the skin. Nurses are to provide a comprehensive skin assessment of the clients. This will include medical history, any factor that places the clients at risk, and nurses assess for abrasions, edema, moisture, rashes, and abnormalities. If an alteration of the skin is present, the nurse should ask questions about the presence of the alteration and the history of the skin condition. An assessment for the nurse is a key factor in decreasing the risk of pressure injury formation, classifying wounds, and determining any treatment. A pressure injury is localized damage to the skin or the underlying tissue that is due to and caused from pressure or pressure in combination with a shear. A skin assessment is completed on admission to a healthcare facility and is to be performed daily or minimally once per shift. Erythema is a redness of the skin that is due to the dilation of blood vessels. Erythema is classified as blanchable or non-blanchable. Blanchable erythema is a redness of the skin that temporarily becomes white or pale when pressure is applied. The area will return to red when the pressure is released. Non-blanchable erythema is a redness that does not go away when the pressure is applied. This indicates to the nurse that there is structural damage that has occurred in the small vessels that supply blood to the underlying skin and tissues. For obese clients, they are very susceptible to an increase in pressure caused by the weight of additional abdominal fat. The nurse needs to assess for pressure ulcers between skin folds. There is an increased risk for moisture-related skin disorders and infections. Moisture-associated skin damage is a form of dermatitis that develops when skin is exposed to irritants. These irritants are in the form of feces, urine, stoma effluent or stoma liquids, and wound exudates. Excessive sweating, increased local skin temperature, and an abnormal skin pH within the deep skin folds all predispose the client to moisture-associated skin damage. Acute wounds are either intentional or unintentional. Intentional wounds include those that are created during a surgical procedure. An unintentional wound will develop due to traumatic injury, like burns, punctures, or gunshot wounds. Chronic wounds develop over time due to the disruption in wound healing process that is associated with acute wounds, or due to conditions that cause alterations in blood flow. These conditions would be chronic venous insufficiency, peripheral artery disease, or diabetes mellitus. Older adults and clients who smoked, that are undernourished, immunosuppressed, immobilized, or have an infection in a wound are at a greater risk for developing chronic non-healing wounds. Nurses must recognize the three major categories of chronic wound for the lower extremity. These are venous disease wounds, arterial disease wounds, and neuropathic disease wounds. These wounds predispose to the development of pressure ulcer formation. Wounds are assessed according to facility policy. Nurses most commonly use the following methods to measure the wound size. Nurses can trace around the circumference and calculate the wound surface area using a see-through film. They can measure length and width of a wound using a ruler. They can measure the depth and the tunneling. Tunneling is a narrow channel or a passageway extending from the base of the wound. This is performed by inserting a sterile pre-moistened cotton-tipped applicator under the wound edges until resistance is met, and the depth is then marked on the applicator and measured using a ruler. The depth can also be measured using only a ruler. Other assessment changes that are noted are changes in skin color, the amount and the odor of any exudate. Wound exudate may be classified as serous, serosanguinous, sanguinous, or purulent. Serous exudate is clear. Serosanguinous exudate is pink tinged due to a mixture of serous fluid and blood. Sanguinous is blood exudate, and purulent exudate is a pus exudate that indicates an infection. Wound documentation must be completed to permit future comparisons in the appearance, the size, and the healing of the wound. Pressure injuries routinely are located on a bony prominence. Bony prominences are heels, toes, the sacrum, hips, elbows, shoulders, and the back of the head. Pressure injuries develop due to prolonged pressure over an area of skin or due to a combination of pressure and shearing forces. Shearing forces are exerted when the client is moved, and these forces cause the parallel skin surface to be pulled, causing the tear. There are risk factors that contribute to pressure injury development. the exposure to moisture, tearing, cuts, bruises, and friction. Friction is considered the force created when two objects rub together. This is not a direct cause of pressure injuries, but it does cause trauma to the skin and underlying tissues. Pressure injuries are often encountered in healthcare settings. They have both physiological and psychological impact for the client. These injuries can cause pain, prolonged healing, and they are potential sources of infection. The Braden scale is a risk assessment tool that is used to determine if there is potential in tissue injury damage. The Braden scale rates a client's risk for alteration in tissue, and it uses 6 categories: sensory perception, the amount of moisture, the activity of the client, the mobility of the client, nutrition status, and friction, as well as shear. The lowest overall score on a Braden scale is 6, and the maximum score is a 23. The lower the overall score for the client, the greater the risk the client has for alterations in skin and tissue integrity. When staging for a pressure injury, the nurse will observe for non-blanchable erythema, the amount and depth of skin and tissue loss, the condition of the tissue in the wound bed and surrounding areas, the presence of any dead tissue, any tunneling or undermining of the wound. Undermining is an open area that extends under the skin surface along the edge of the wound. A stage 1 pressure injury. The skin is intact with localized area of non-blanchable erythema. These injuries may be difficult to detect in darker pigmented skin. A stage 2 pressure injury is a partial thickness skin loss with pink or red viable tissue in the wound bed. The tissue is moist and deeper tissues are not visible. A stage 2 pressure injury may present as a ruptured serum-filled blister. A stage 3 pressure injury is a full thickness skin loss with visible adipose tissue. The granulation tissue is often present and the wound edges may be rolled. Dead tissue may have formed and undermining and tunneling may be present. A stage 4 pressure injury is characterized by full thickness tissue loss. Fascia, muscles, tendons, ligaments, cartilage, and or bone are visible. The edges of the wound are rolled, undermining and tunneling may be present, and dead tissue may be seen. In an unstageable pressure injury, this is full damage in the wound bed, and it cannot be determined because of the obscured full thickness skin and tissue loss. The wound is often covered with slough. Slough is a yellow, stringy, non-viable tissue that can be found in a wound base, or there may be eschar present. Eschar is hard, non-viable, black or brown tissue. Often when the eschar is removed, the wound will reveal either a stage 3 or a stage 4 pressure injury. When documenting pressure injuries, the nurse must include the location, the stage and size, a description of the tissue, color of the wound bed, the condition of the surrounding tissue, the appearance of the wound edges, the presence of any undermining or tunneling, and if there is any foul odor that is present. The nurse needs to document the presence and the characteristics of wound drainage, and they need to report any pain at the wound site. Clean versus sterile dressings. A sterile dressing is applied after surgery and kept on the incision site for 24 to 48 hours. If the dressing becomes saturated or loose, the dressing is changed using a sterile technique. After 48 hours, the wounds are managed using clean technique during dressing changes. Dry versus wet dressing. Dressings applied as dry or moistened depends on the wound type as well as the provider preference. Dressings are changed according to the provider's prescription or facility policies. This is often daily or every 2 days, or it may be PRN due to excessive drainage. Open dressings are gauze bandages. These are often moistened with 0.9% sodium chloride. The gauze dressings are used to pack wounds to assist with the debridement process. These are known as a wet to dry dressing. As the gauze dries, it clings to the tissue inside the wound. However, when the gauze is removed, the tissue that has clung to the gauze are removed with the dressing. This can cause damage to the new tissue granulation. Semi-open dressings have 3 layers. The bottom layer is a layer of knit gauze that is closely woven. It is often infused with therapeutic ointments. The middle layer contains padding and absorbent gauze. This is followed by a final layer of adhesive. Semi-occlusive dressings, these have more diverse properties than an open and semi-open dressings. These vary in ability to cover the wounds and control moisture as well as bacteria. There are various formats of semi-occlusive dressings. Films. These reduce the ability to absorb moisture. They are self-adhesive transparent dressings. They are used to cover superficial wounds that have minimal exudate. Hypercolloids. These are used for small abrasions, superficial burns, pressure injuries, or post-operative wounds. These are gel-like dressings that occlude the wound, maintain moisture of the wound bed, have bacteriostatic properties, and stimulate the growth of new granulation tissue. Alginate dressings are recommended for moderate to highly exudative wounds. These provide hemostasis, have high absorbent properties, and remain in the wound for several days. This helps to decrease the amount of dressing changes. Hydrofiber dressings are used for moderate and highly exudative wounds. Hydrofiber dressings provide high absorbency and can stay in the wound for several days. Foams are used in wounds with mild to moderate exudate, but these require more frequent dressing changes. Polymeric membranes are used in mildly exudative wounds. These stimulate the growth of new epithelium and do not stick to the wound bed. Hydrogels are used in dry wounds for debridement of necrotized tissue and eschar. These work differently because they provide moisture or draw moisture away from the wound depending on the needs of the wound. For sutures and staples, the main role for these is to keep the wounds secure and intact. During primary closure, the surgeon applies either sutures or staples to the edges of an acute surgical or a traumatic wound. The benefit of staples is they can be placed more rapidly than sutures, and healing is faster with a stapled wound, routinely within 7 to 10 days. Sutures are made from synthetic materials like nylon or polyester, or natural fibers like silk, linen, and dried animal intestines. Both synthetic and natural sutures can be absorbable or non-absorbable. Synthetic absorbable sutures routinely dissolve within days to weeks. Sometimes they can last up to 2 months. Skin adhesives are alternatives to sutures and staples. Skin adhesives form protective, waterproof covering over a wound. These are used for small, minor wounds or wounds with straight edges. These adhesives are applied as a liquid or a paste, and they take mere minutes to set. The glue will peel off within 5 to 7 days. Negative pressure wound therapy is used to assist in healing and the closure of large wounds by reducing the edema that surrounds the wound, and it increases the granulation tissue formation. A foam dressing is applied over the wound and then covered by a semi-porous occlusive dressing. Then, suction is applied. Suctioning during negative pressure wound therapy can be applied constantly or intermittently, depending on the wound needs. For wound drains, surgical procedures that often require drain placement will include the chest, breast, abdomen, thyroid, or any plastic surgeries that utilize a flap procedure. Wound drains are classified as passive or active based on the mechanism of action. Passive drains rely on gravity to remove accumulated fluid from the body cavity or the wound. Active drains use negative pressure to suck drainage from the wound or body cavities. Drains are also classified as open or closed. Open drains remove fluids to air. Closed drains send fluids to closed containment systems. Drains are removed when the total wound drainage for a 24-hour period is between 30 milliliters to 100 milliliters, or it depends on the provider's preference. A Penrose drain is a flat, pliable, passive drain that uses gravity to drain accumulated fluids. The Penrose drain is an open drain, meaning that there is no collection chamber for the wound exudate. To collect the drainage from a Penrose drain, a perforated 4x4 gauze is placed around the drain and the fluids are collected directly onto the gauze. The sterile dressing should be maintained at the drain site for 24 to 48 hours. A portable wound bulb suction device, or a bulb suction drain, is an active, closed system drain that uses negative suction to drain fluid from the wound. It is composed of a tube that has a bulb connected at the distal end. The tube is inserted into the wound and the bulb remains outside of the wound. The bulb is emptied minimally every 8 hours or when more than half full. A circular portable wound suction device is a special type of wound drainage system designed to continuously suction drainage from the wound by providing low vacuum pressure. This consists of a circular drainage device that has a spring that is squeezed flat on insertion. Hygiene for individuals is individualized. It is a structured regime for hygiene is more effective in the prevention of pressure injuries. When the skin is regularly cleansed, any unwanted substances are removed. Hydration assists in the elimination of waste products and movement of nutrients throughout the body. The nutrition plays a major role in decreasing the risk for alteration in skin integrity and promotes wound healing. For circulation, when blood circulation is compromised, the body's tissues suffer ischemia from lack of oxygen. This results in reduced nutrient supply to the cells and failure to remove the metabolic cellular waste. Primary healing is also known as first intention. This type of wound healing occurs in clean lacerations and surgical incisions that have been closed with skin adhesive or sutures, and these are the fastest wounds to heal. Secondary healing or secondary intention is wound healing process that takes place when the wound is left open to heal and the granulation tissue forms from the bottom up in the wound bed. This healing process is prolonged and the wound bed needs to be kept moist for proper healing to occur. This type of healing has a greater risk of infection because of direct contact with the environment. Delayed primary enclosure is also known as tertiary intention. This is a combination of primary and secondary healing. The wound is left open for 5 to 10 days before it is closed with suture. This decreases the risk of infection in wounds that are not considered clean at the time of tissue injury. Wounds heal in 3 phases: hemostatic or inflammatory phase, proliferative phase, and the remodeling phase. The hemostatic or inflammatory phase begins the moment injury occurs and lasts 3 to 6 days. Early in the phase, the blood vessels will constrict and damaged tissues release proteins that trigger the activation of various clotting factors. These actions will work together to stop bleeding. Once bleeding is controlled, histamine is released. This results in vasodilation and an increase in capillary permeability. This is important because it increases blood flow to the injury, allowing white blood cells to flood the area and assist to clean the wound. Besides acting as phagocytes, the presence of certain white blood cells or neutrophils enhance the release of cytokines and promote new blood vessel formation. It's also an increase in fibroblast and keratocyte formation, and it aids in tissue maturation. The proliferative phase begins 3 days after injury and can last 24 hours. During this phase, the blood supply to the wound continues to improve. Granulation tissue, composed predominantly of fibroblasts and collagen, develops simultaneously with the new blood supply. The presence of collagen strengthens the wound, allowing it to mature as the wound closure begins. As the wound matures and closure begins, re-epithelialization occurs as the keratinocytes around the periphery of the wound begin to move to the center of the wound to cover and fill the space. The remodeling or maturation phase is the last phase of wound healing. This will begin around day 21 and can last for more than a year. The collagen formation in the granulation tissues of the wound during the proliferative phase is replaced with stronger collagen. This helps to aid in the wound maturation. The wound closure continues during this phase as the myofibroblasts secrete proteins that produce contractile force that pulls the wound edges together. There are various complications that can occur with wound healing. Dehiscence is a complete or partial separation of a suture line and underlying tissues. This occurs when the wound fails to heal properly due to poor surgical technique, infection, or the presence of foreign particles in the wound. This is potentially a serious complication that has a 30% mortality rate. Dehiscence generally occurs 7 to 10 days after surgery and is often preceded by serosanguinous discharge from the wound. If dehiscence occurs, the nurse should notify the healthcare provider, administer pain medications as prescribed, and cover the wound with moist, sterile dressings, implement IV therapy, and prepare the client for return to the operating room. Evisceration occurs when the wound and all layers of tissue under the wound separate, resulting in the protrusion of intra-abdominal organs through the suture line. This is an emergency situation that requires immediate attention. Sterile saline-soaked dressings should be placed over organs while the client is prepared to return to surgery for the reduction of organs back into the abdomen and the closure of the wound. Bleeding and/or hemorrhage. Bleeding may be either internal or external. Blood vessels in the wound constrict to provide hemostasis and stop bleeding by triggering a mechanism called the clotting cascade. During the clotting cascade, platelets accumulate at the site of the bleed, triggering the release of growth factors that initiate the healing process. A new matrix is formed from fibrins. This helps stabilize the wound. A hematoma is an accumulation of blood, and a seroma can occur if the clotting mechanisms fail. Depending on the size, these collections of fluid may cause the incision to separate, placing the wound at risk for infection, since bacteria can now enter the deeper layers of the wound and infect the accumulated fluid. Because of increased pressure and compression to blood vessels caused by hematomas and seromas, wound ischemia may occur. This can lead to tissue necrosis. Anticoagulant medications and obesity place clients at a greater risk for hematoma and seroma formation.